The first talk is basically on who we should be screening and what we're going to see in some of those. And I know some of my colleagues at UC San Diego really don't believe we can do it yet, but as soon as we show them like 5 cases in a row of abnormal, three-vessel trachea views, they go, oh yeah, it's really there. We should be seeing it on anyone. And so sometimes it just means seeing a bunch of cases to believe that you can really do it as a screener. And I am truly here as a screener. I'm not here as a cardiologist or as someone who does fetal echo. I screen, and hopefully these images will help you believe that you can screen in your everyday patient that comes in your practice. So the fetal factors that make us look for heart disease are, if we get an increased nuchal, you should be thinking, is there a heart lesion? Let me look at that heart a little bit harder. If you have a cystic hygroma, things that we see all the time, an abnormal cardiac axis, abnormal screening from the 4-chamber view in grayscale, and then abnormal screening from the color pictures of 4-chamber and 3-vessel trachea view. Abnormal situs. Anyone who does 2D on second trimester should always be able to figure out situs in the first trimester, just like you always do in the second trimester. Single umbilical artery, we don't always pick it up in the first trimester, but if you happen to see it, then that should make you go looking for heart disease. If you have extracardiac malformations, and then there is screening that we've used with the tricuspid and mitral valve regurg and reverse flow in the ductus. There are also maternal reasons that we should be thinking about abnormal hearts, poorly controlled diabetes, a history of heart disease, morbid obesity, metabolic disorders, exposure to teratogens, rubella infection, autoimmune disease, family inherited disorders, and in vitro fertilization all increase your incidence of heart disease. So first we'll go through this patient that has an increased nuchal at 12 weeks, and this one is measuring out about 6.5, so certainly significantly elevated. We know from a couple different papers, I just added this one here from 2013 of a meta-analysis of 20 studies with over 500 cases of major heart disease and normal karyotypes. That when the NT was greater than the 95th percentile, we had a sensitivity of picking up heart disease in 44 percentile and specificity of 95, and when you went above the 99th percentile, that went to a specificity of 99 percentile. And then one of the earlier studies of combining data maybe presented slightly different way, that the prevalence of heart disease was about 38 per thousand, and then if you had a NT that was from 2.5 to 3.4, it was 7 per thousand, and then if it was greater than 3.5, it was 78. So we used 3.5 for a long time as who we should be doing fetal echoes on, but we moved it down because the state of California and their prenatal diagnostic screening changed it as well to the 3.0, and I think this is where you really have to think about whether you're going to move from transabdominal to transvaginal in looking at the heart and the fetus for anything else that you might identify and not just staying with your transabdominal. Here was a patient with 3.1 that we had, and when she came back in the second trimester, she had a hypoplastic right heart, just to show you that it does really play out. Cystic hygromas we see as a fairly routine in our practice. This was a large series of 944 patients with cystic hygromas. 55% had abnormal karyotypes. 29% had a major anomaly in a normal karyotype, and 15% had heart disease with a normal karyotype. So these are the types of patients that have these cystic hygromas here. This one was 9.3, and this fetus had a bicuspid valve and had Turner syndrome. Okay, the axis, I think when Elena, who's one of our speakers, wrote this paper, I was just blown away. I thought, wow, I knew that abnormal axis went with some specific heart disease, but I didn't realize that in this series where they had 6 cases, there were 4 that had heart disease, and they were all different lesions. So the axis is really good for not just tetralogy of Fallot, which is the one that I classically think of, but it happens with many different heart disease. We're going to have the drop down of our major from the C-spine to the sternum, and then the axis across. Then they had a follow-up study, same group, with almost 200 cases from 3 different centers, and the number that was normal was 45 degrees, which we always quote. And there, 75% basically had an abnormal axis, and this was better than the enlarged NT or the tricuspid regurg to help find that. So the axis is very important. Here's a deviated heart, and when you drop the line, there's the one from the spine out, and then when you bring in the line of the axis, you can see that it is definitely greater than 45 degrees. And this patient ended up with a single ventricle with double outlet right ventricle and a malposed great vessels. And so this is another tip to you is when you think you see something abnormal and you don't quite have it, or you don't have a fetal echocardiographer specialist in your community for first trimester, often bringing them back in 2 weeks can really make a huge difference. And I know a lot of people want to bring them back at 16 weeks when you can do an early amnio, or even 15 to 16 weeks, and that's okay. You kind of have to take it your patient by patient. But often I find 2 weeks, anytime you find something in the first trimester that you're not sure about, whether it's a brain or whether it's a heart or something else, 2 weeks often makes a big difference. And here you can see that axis again and realize that the stomach actually was on the wrong side as well. Okay, so we use both grayscale and color Doppler imaging. This was one series with 10 studies. And 1,200 patients, and they pooled their sensitivity of 85% and specificity of 99%. And when I read that paper, I was just blown away too, because I didn't think our practice was anywhere near as good as that. And I think when you have experts, it's different than when you have screeners. And so we have to work together to get from one to another. In San Diego, I do not have a provider that does first trimester hearts. I have to send them to Los Angeles. And some families go easily to Los Angeles. It's 2 hours up the road. And some families, I got a letter from one recently, was very annoyed at me for recommending that they consider going to Los Angeles for this. And they had to wait till 18 weeks. And they thought I was doing research on their baby by calling a right arch in the first trimester. So, you know, it's all how you talk to them and trying to explain. And some people get it right away and some people don't. So here was a query for chamber atrioventricular canal based on this picture. When she came back at 18 weeks, she did indeed have offset her valves, but it was not a true AV canal. So I think sometimes you're just going to get into the ballpark. You're not going to get the exact answer. And when I went to try to find a normal video clip to show as the normal four-chamber, many of them looked like the same thing of a possible AV canal. So it just taught me when one point you look at it and you think, I've got it, I get the follow-up, I know now I can call that for the future. It's just not always the case. You got to start looking at every case and looking at one part of it, like the crux on every patient, and see what you think before you are really ready to call anything clearly abnormal. This was another case with pretty small images here, I'm sorry, but and with the lights out there, it's not quite as good. But here she is when she comes back at 20 weeks, and indeed, she did have that elevated NT of 4.8 on her original, and then she came back and she was screened positive for 21 on her NIPT and on amniocentesis. So one that's a true one. Okay, then color. I know a lot of people who do screening don't really want to add color, but you're not going to really pick up most of your heart lesions in the first trimester if you don't do some color. And you can see the axis much better in that the two ventricles are symmetrical by turning on color. Anyway, here's another one that's abnormal with the chamber here, right ventricle having much more color than my left ventricle, and there was a normal for comparison. And then here we go Another, you can't see anything in the left ventricle down here. You only see it in the right ventricle. And then there was a single vessel on the 3-vessel trachea view. And that's one of the things. You have to reproduce it on multiple, angles to convince yourself that it's only one vessel. But that one vessel really helps you in making these decisions. Here's one, I guess this is the follow-up of this one, the previous one at 17 weeks. And you can see the right filling and nothing on the left. And then on the 3-vessel view here at the 17-week scan, you can see that pulmonary artery being quite large in comparison to the aorta. And it really looks like there's a persistent left SVC there too. Okay, so moving up to think about the 3-vessel trachea view in the first trimester, it's just like it is in the second trimester that you look for the PA coming over to the left and the aorta coming to the left as well. This one you can see that the aorta is on the right and the trachea is in the middle, in contrast to having them come together as that V. And at 23 weeks, this was confirmed out. Here it is on the trachea in the middle and the aorta on the right, the PA on the left. But you can see the PA coming over here to the right and the aorta coming over here to the right. And I have to confess that I read this case and I missed this right-sided aortic arch because I just saw the two coming together and I wasn't thinking about right versus left. I think if you will go down and have your heart on the same sweep of your 3-vessel view, even if it's not on every sweep, if it's on one sweep, to show that your heart and your PA are on the same side, that now I pay a lot more attention to not just seeing them come together as my arrow, but whether it's right or whether it's left. It's coming over here to the right. But notice I don't have the heart in that clip. So you have to have the heart if you're going to figure out whether you're on it or not. And this patient went on and had an MRI showing the right heart aortic arch with a mirror image and no vascular ring. Okay, so this is one that happened this year where I called this a right aortic arch because it looked to me like this was the spine and the trachea was here and they were both going to the same side. But when she came back at 18 weeks, it was a left arch, and this was really the aorta going up and not the trachea here. And the trachea was really in the middle and not over here. And so I think that when you first start, you don't always know where this one, she had a normal left arch when she came back. And I think the spine really is a little bit further back, and I'm really seeing part of the vessels a little bit lower down where the pulmonary is coming. So that was the one. She was very upset that I had told her she might have a right arch. Okay, here's a right greater than left disproportion with a single great vessel. And you can see that you don't have as much filling here on the left, and here it is on the clip. And then when you move up, you only see one great vessel, and it's kind of curly, which sometimes happens. It takes a little almost kinking list sometimes. And when she came back at 18 weeks, she had a crisscross aortic valves with a double outlet right ventricle and a dysplastic tricuspid valve and a hypoplastic aortic arch. So lots of things that we may not see everything on our first trimester. We'll see part of it. But that part of it can allow you to go on and do further testing and to be able to get them to get their echocardiography wherever they're going to use it to make decisions, whether they're going to use it in the first trimester or whether they're going to use it in the second trimester for further genetic testing and management. So abnormal situs is something that, of course, we know that we should be able to pick up at any time. This one, you can see that the heart is on the right and the stomach is on the left. And I know this is, the situs thing is basic, but we've had multiple cases come in that when you pick it up later, they've had 2 or 3 studies before and they haven't picked up the abnormal situs. So everyone as a screener should at least make sure that they're on the same side. You know, I mean, we should be able to figure out left and right on every fetus, but you should always notice if the heart and the stomach are on different sides. And even in our community, I mean, we've noticed and we've tried to re-educate, go backwards and say, listen, the stomach's on the wrong side or the heart's on the wrong side, and that should at least make you refer on. So this one, at 12 weeks, we thought it might be a double outlet right ventricle because it looked like the great vessels were parallel, but when she came back, we found that it was transposition with dextrocardia. And so at least they're both in the same ballpark of we know that we need to find something. So here is the initial, or this is 20 weeks, here we go. So I think and when you start screening, you are trying to get into normal, abnormal, and then go a little bit further as what do you think it is. But you're better off, I've learned through my whole career, it's been a humbling experience that lots of times what you think you know, like I thought I knew that right arch was a right arch, and I was wrong, so you're better off to be a little bit humble and say, I think it's a right arch. I'd like to get additional studies and figure out for sure, unless, you know, it's your area of expertise where you have a lot more experience than the average person doing this as screening. So another place is looking at single umbilical arteries. This is if you happen to turn on color to decide whether you're going to have it. We turn on color briefly for the color heart and for the 4-chamber view and for the 3-vessel trachea view. We don't normally turn on color for the umbilical cord insertion or the bladder in the first trimester just because of the bioeffects and the AIUM saying that we're not supposed to use color unless we need color. So you have to make decisions as to whether you think that's necessary for you to make that call or not. So I find sometimes that my sonographers will turn on color, and whether it's because they saw it on grayscale and then they want to confirm it or not, if you turn it on and off quickly, I think that's fine. I think you don't want to turn color on and leave it on for long periods of time while you're trying to figure things out. Here's a 12-week that we don't have the second vessel, whereas here you can see normal for comparison. Here, one of the extracardiac malformations that's associated with heart disease is the omphalocele. You can see here, there's the spine. Here is the spine back here. And I know that it's 12 weeks and you want to think about physiologic herniation. Certainly you want to think about it, but you usually can differentiate physiologic herniation from a true omphalocele or gastroschisis. And if you can't, you need to bring them back in a week or two to figure it out for sure. Usually the bowel is back in by the end of the 11th week. Ductus venosus pulsatility, increased impedance to flow in the ductus from 11 to 13 weeks. I think the data on the pulsatility I have here for you in this talk. It improves detection of trisomy 21 a little bit. We find now with NIPT that we're not using this as much as we did in the past. But the concept I thought I should at least give you that the normal, you're not going to have this reverse flow, and in the abnormal, you will. And when it was originally talked about, it was for this group that were sort of moderate risk from the 1 in 50 to 1 in 1,000. But today, when you find anything, we just go directly to NIPT, so it's not the same decisions. Greater than the 95th percentile, you can see over here, the numbers are going to vary for gestational age, but they're all pretty close there to 1.4. And in this study, they looked at 10 to 16 weeks and had over 1,000 participants, and they found that it was pretty good for trisomy 21 and 18. With a likelihood ratio of 18, and for 21, 67%. But still small numbers, overall. Tricuspid regurg is another issue that we think about in both the first trimester and later on in pregnancy in the second and third trimester. And in the first trimester, the Fetal Medicine Foundation came out with looking for tricuspid regurg as a risk factor for aneuploidy. And you can see that the image, once again, should be as to occupy most of the chest, as you'll see in the next image. The pulse Doppler sample should be a small little volume of 2 to 3 millimeters, and it should be positioned right over the tricuspid valve, in contrast to, the pulmonary and aorta that you saw earlier, where it was right behind it. This one needs to be right in it. And we're looking for this velocity to be greater than 60 centimeters per second. Here we go with a picture of where the sample should occur, and notice how large this is in order to find it. I just was looking at the first trimester anatomy guidelines that the AIOM is trying to set up now for what we should be looking for. And it's going to be the first guideline I've seen where this, besides the nuchal, where you actually have to have your image filling half of the image. And I see when in my radiology practice, especially people at night, I don't know, just because they tend to be junior, they tend to be not around their peers as much, whatever, their images of hearts and abdominal circumferences and BPDs, they're tiny. I always call them postage stamps. These are postage stamps. How do you expect me to make the diagnosis of anything unless you're going to make it bigger? But we keep trying to figure out for cardiac screening how to get the screeners to be able to see things that these sophisticated experts can see, right? And really, number one is getting the image bigger in the field for them to be able to see it. So I think that's the one thing we have to try to figure out, how we're going to get the screeners to do it. And no matter how many times I tell them, it's still like QA, 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 QA all the time. So maybe if the guidelines have it in there that you have to have the image, 50% of the image, whatever you're looking at it, maybe we'll get the quality that we need. So tricuspid, once again, remember it was this 60, greater than 60 that we need in order to pick up this as a risk factor for trisomy 21, 18, and 13. And so once in a while, you're going to see that color flash on your image, and then the reversal of flow, and then you're going to do a pulse Doppler to see whether you have really do have enough regurgitation. Okay, the echogenic focus, the bane of our existence in second trimester. I know every patient that I walk in and explain that they have an echogenic focus, I say I see it at least 3 times a day here. And so it always relaxes them as soon as I can tell them that it's so common. But what do you do about it in the first trimester? We have quite a bit of data in the second trimester and lots of papers. But in the first trimester, we have this one paper mainly by, I don't even know how to say his name, from 2008. And it came from Europe, of course, where they do lots of first trimester studies. And in this study of 1,000 participants, they had 22 of them out of 228. And it was about a 10% of the 21s had echogenic focus, and it raised your likelihood ratio 6.4. Whereas in the second trimester, we use 1.1 as our risk of going up likelihood factor. So since this is one paper and really not a lot of data, it's got good data, and it didn't just look at EFLV, it looked at pylectasis, and it looked at other markers as well. I always say it increases your risk a little bit. We don't know. I don't use the 6. I just say it increases a little. We see it, every day in our second trimester practice. Some people decide they want to do an IPT just with the EFLV in the first trimester, and a lot of people just decide to wait and see what happens on the next one. And then here is, this is interesting. This one should have been in the previous part, but this is just showing the regurg on color. Let me show it again on PowerPoint. There it goes. Just a little bit right there. And this patient did have trisomy 13, but she also had other things. She had a cleft lip and palate, and she had holoprosencephaly suspected based on the butterfly choroidal view. And so, yes, regurg can be abnormal. absolutely, in color, and we do look at it and we do think about it. And it's a matter of how much it is as to whether you're going to counsel about it or whether you're not. So hopefully I've shown you enough for trimester cases for you to get a feeling that if you will start trying to just push your color on and off to get your 4-chamber view and your 3-vessel trachea view, that you too might be able to identify some of these heart lesions. Thank you very much.